Okay, we can start. Well, welcome Dr.Graham Neilsen. I'm Gina, I'm hosting for Michelle today. So before we start, thank you to everyone that will be logging on or watching this session later on. So for this seminar today on errors in the diagnosis of sexually transmitted disease, Dr. Graham Neilsen has over 30 years of experience in sexual health and HIV, working globally with United Nations, agencies, and international development organizations in various countries across Africa, Asia, Eastern Europe, and beyond. He played a pivotal role in establishing the gender service at Royal Brisbane Women's Hospital as the senior staff specialist. He formerly served as the co-chair of the Queensland Health Sexual Health Clinical Network and was a member of the Sexual Health Ministerial Advisory Committee. He's a member of both AusPATH and WPATH. We are very proud to have him on the MAG panel. Yes, over to you, Dr. Neilsen.
Okay, so shall I share? Okay, so just bear with me a moment. Okay, so good morning, everybody. Both those who are seeing me do this presentation live, but also those who will be viewing it as a recording later on. I have taken the liberty this morning of broadening the topic a little bit to other sexual health issues, and I think you'll appreciate why that is as we go through the presentation. My area of work is not generally very well understood, and those who do think they know what we do generally have a somewhat narrow view of what they think that we do. So I'd like to address that as well up front. So I've named it just sexual health, medico-legal issues, and you'll see where we're going in a moment. I have received funding in the last 12 months from Pfizer Pharmaceuticals to do a presentation, and I'd like to begin the overall presentation by acknowledging the Yagara and Turrbal people, who are the traditional owners of the land from which I'm presenting today in Mianjin, also known as Brisbane. I'd like to also pay my respects to elders past and present and extend that respect to other Aboriginal and Torres Strait Islanders who are present with us today. So, as I was saying, what is this thing that we do as sexual health physicians, sexual health medicine? So the topic that you were given about the narrow scope of sexually transmitted infections, which typically includes HIV infection as well, that's not all there is to it. So sexual health medicine deals with individual, population, social, interpersonal, microbial, and immunological factors that contribute to sexually transmitted infections, HIV, sexual assault, sexual dysfunction, fertility regulation, and much more. We promote sexual health at both the individual and population levels. And so, as Gina was mentioning, I've done a lot of work overseas. That was pretty much all to do with public health aspects of sexual health. So I wasn't seeing patients. I was doing national program evaluations, drafting national STI management guidelines, and many other things and research. So we work on education, we work on behaviour change, advocacy, which implies political action, policy development, targeted medical and laboratory screening, clinical services, surveillance and research, and specialist support to other practitioners. We support the WHO statement defining sexual health as encompassing human rights related to sexual health, sexual pleasure, eroticism and sexual satisfaction, sexually transmitted infections and HIV, sexual violence, female genital mutilation, sexual dysfunction, sexuality, gender identity, and most of my work these days is related to doing gender-affirming treatment for patients, and then finally, mental health related to sexual health. So the 4 topics that I've chosen include aspects related, medico-legal issues related to sexual assault and forensics, the hazards of inappropriate use of STI diagnostic tests, which is closer to the original topic, then dear to my heart, I suppose, these days, trans and gender diverse healthcare, which is closely linked with the final topic of autism and sexual health. So looking at sexual assault and forensics, the role of my colleagues, physicians, is often providing clinical care after an alleged sexual assault. And then additionally to that role, those professionals involved in actually conducting forensic assessments, all of us should be engaged in a trauma-informed approach with clear guidelines which are respected around the hugely important issue of consent. And wherever possible and appropriate, a chaperone should be employed as well to protect the possible victim. So there are clinical aspects to this, and this slide is really relating to the forensic examination after an alleged sexual assault. There are many layers to each of these bullet points, and many things can be done very well or badly. And depending on the quality of how the work is done, it can support or impede the legal support to the alleged victim. So a detailed history needs to be taken, and that just includes a general health history, past medical conditions and so on, gynecological history, so previous gynecological health issues, also current symptoms, then a detailed history of the alleged assault itself, what happened, what parts of the body were involved, and so on. And then relevant to that, a thorough physical examination, sometimes called the top-to-toe physical examination, is hugely important. Many things that don't seem obvious at the time become extremely important later on. If the person, for example, says that the alleged perpetrator bit them on the arm and the forensic examination failed to examine the arms. And so that would be a major lost opportunity with legal implications. Then, of course, a genito-anal examination needs to be conducted. And again, using a trauma-informed approach and consent, the examination of someone in this situation is often a source of its own trauma. And so under those circumstances, the person needs to be well informed that the consent can be withdrawn at any time if they wish the examination to cease. And that's an area that I think is not completely understood by a lot of people who are less familiar with the importance of forensic examination in the context of genito-anal examination. Meticulous records need to be taken with regard to the documentation of injuries. And we're not just talking about genito-anal injuries that might be related to penetration, but other injuries, as I just described, elsewhere on the body. Forced oral sex is certainly a common experience in sexual assault. And so just as another body site, the mouth is often really important from a forensic point of view. And then, of course, we need the diagnostic testing to be relevant and also to be acceptable to a court. And so there are some diagnostic tests that are deemed insufficient to reach the standard required by the courts. And there are some issues related to how specimens are collected, where they're collected from, and with what particular swabs, and then the tests that are applied to those. And so I've just put a slide, the next slide, really to give you a little bit of a sense of the detail on this topic. So this is adapted from some WHO guidelines outlining the diagnostic tests, the methods used to collect specimens, and then by implication, some of the forensic issues. So you'll see the sites and materials that are used for forensic purposes go way beyond the examination of the person themselves. So apart from the biological, clinical aspects, so That would include specimens collected from the anus, blood specimens, genital specimens, including semen, oral specimens, as I just mentioned, and other things looking elsewhere for indications of sexual assault. So some of them are self-evident, but some of them are less obvious. So it's very important that clothing be collected. Many people who have been through a sexual assault want to have a shower as soon as they possibly can. And of course, from a forensic point of view, that's a disaster. Critical evidence is easily lost in that context. If the clothing is washed soon after the alleged sexual assault, then critical materials that may demonstrate the presence of the perpetrator, and in particular evidence that does imply sexual activity, such as the presence of semen, that evidence could well be lost. Hair, again, this is sort of a general forensic phenomenon. Whose hair was found at the scene and on clothing? So fibers, hair, and semen elsewhere on the body, for example, on the skin, as you'll see below. Specimens taken from the nails of the alleged victim and the alleged assailant. In the context of women, foreign materials collected from sanitary pads and tampons, including semen, blood, and hair. Again, saliva, so not evidence of sex per se, but certainly evidence of assault, so biting, evidence of saliva at other sites, so on the skin, showing evidence of biting, licking, and blood on the skin, and so on. Foreign material that can be used to correlate with the location of the alleged assault. So soil samples on the skin, for example, matted hair may contain foreign materials that show or could be used for forensic purposes to demonstrate consistency with soil sampled at the site of the alleged assault. And then, of course, drugs, urine and blood specimens can be used to demonstrate the presence of alcohol and other substances that may be very important in terms of the critical question of whether the person was intoxicated. We've all heard many tales of spiked drinks, for example, where someone is actually given something in a bar, and with that they become disoriented and potentially unconscious as a result of illegally administered drugs, which can be measured in blood and urine. On the right-hand side there, you can see the sort of specimens that are required. Most of them are fairly self-evident, but they include swabs that can be used for genetic testing for the organisms, as well as the alleged perpetrator, so the DNA of the alleged perpetrator. Sterile containers to make sure that there are no contaminants derived from the environment after collection, and implicit in all of this, of course, is the essential requirement for a chain of custody to be able to be established from the time of collection to the time of testing. And those who are working consistently in this area are well aware of the need to be able to demonstrate chain of custody for later use in the court setting. Next slide really is touching on the original topic about the inappropriate use and errors that can be related to the use of STI diagnostic tests. I've just given a couple of examples here, and this, by extrapolation, you can see how these tests can carry medico-legal consequences, both against clinicians in terms of malpractice, but also be exploited often inappropriately in the context of legal matters such as divorce proceedings. So herpes serology is really the top of my list in this context. I was president of the Australasian chapter of sexual health medicine when we developed 5 major areas of error in clinical practice, and the website describing those is at the bottom of the slide there. Herpes serology was at the top for a number of very good reasons. For those of you who are unfamiliar with how we typically do testing for herpes, there are critical parameters that are important both clinically but also medico-legally. Timing, when was the infection acquired, at what site is the infection present, and what type of herpes is involved. And there are both diagnostic tests that test for the DNA of the virus itself. And so the ideal specimen, of course, would be a swab collected from a site in question, be it from the genitals, the anorectal region, or the mouth, or elsewhere. And of course, if that test is conducted with a genetic test such as PCR, polymerase chain reaction, that tells you very clearly that on that day, at that site where the specimen was taken, herpes of a specific type was present, really clinching the diagnosis of and type-specific herpes type 1 or type 2 being present at the site of specimen collection. The problem with serology being based on a blood specimen is that it is certainly not site-specific, but it also tells you nothing about timing. In the community, something like, it's decreasing somewhat now, but early on, maybe a decade or more ago, around 90% of the community would have tested positive for herpes simplex virus type 1. And the reason for that is the reason, which is very unlikely to be medico-legally relevant, namely the source of that infection was most likely cold sores, which were acquired by the person in childhood. And thereby, this is evidence that really tells us nothing about whether this person was infected with herpes recently. And so for those reasons, we strongly discourage clinicians, both for clinical reasons, but also for medico-legal reasons, that they avoid, unless they can really come up with a very strong argument, that they avoid using herpes serology in those contexts. It's vexed and may well bring action against a clinician for using an inappropriate test in that context. There are other organisms which are probably unknown to a lot of people in the audience. Urea plasma is often tested for. Urea plasma and mycoplasma. There are various species. That's what the SPP there means. Different species of both urea plasma and mycoplasma. And my colleagues generally view most of those infections or positive testing for those organisms as being irrelevant to a diagnosis of a sexually transmitted infection. In other words, we would strongly discourage their routine use because they're, generally speaking, completely misleading about there being a treatable problem for the patient. There is an exception to that, which is becoming quite diagnostically challenging and clinical management challenge, and that is one specific species of mycoplasma called Mycoplasma genitalium. And so, again, we discourage routine screening for that infection, but in symptomatic individuals, we recommend that Mycoplasma genitalium testing be conducted, and it's a difficult clinical dilemma because this organism in recent years has rapidly developed resistance to a range of antibiotics. And so testing for antibiotic resistance is really part of that package and can also pose, by extension, its own medico-legal issues in terms of appropriate management, failure to follow national guidelines, for example. Then, similar to herpes, less and less these days we see clinicians using serology, blood testing to diagnose chlamydia trachomatis. Often when serology is used for this purpose, it will come up with a positive result, which again is misleading because other species of chlamydia, for example, chlamydia pneumoniae, which causes chest infections, can cross-react with the reagents used to test for chlamydia trachomatis. So positive serology may indicate nothing at all relevant to sexually transmitted infections and merely be evidence of a previous chest infection and irrelevant to the question at hand. I'd like to move on now to a legally very challenging and politically very challenging area, which is to do with trans and gender diverse healthcare. And I'd really like to focus here, rather than on the possibility of medical negligence, I'd like to just bring to your attention the fact that the legal environment for clinicians such as myself caring for minors, so young people under the age of 18, this legal situation has become an absolute minefield over the last 10 or 20 years with major, I'll call them flip-flops, but almost complete reversals of the legal situation for young people and their families seeking gender-affirming treatment, be it the use of puberty blockers, stage 1 treatment, or stage 2 treatment with hormones. So in 2013, just over 10 years ago, the Family Court of Australia decreed that the Family Court was not required to decide around stage 1 treatment, and that stage 2 treatment with hormones was also okay so long as the child was Gillick competent. And for those of you who may not be familiar with Gillick competence, this basically is the assessment that the young person understands the implications of what they're consenting to and the long-term implications and also the hazards of the treatment to which they're agreeing to receive. So Gillick competence is widely used in healthcare for young people, but in the context of gender-affirming treatment, it has been strongly contested through the Family Court. And all of this, sadly, is not through legislation. It's all based on case law. So individual cases and a judgment by a judge on the Family Court can reverse what is by implication national policy for how we conduct care, especially from the point of view of consent. And so this has gone backwards and forwards several times, as you can see on the screen. So 2013, it's a fairly permissive approach, again reinforced by Reed Kelvin in 2017, that if there is no dispute between the child, the parents, and the doctors, hormonal treatment could proceed. Then in 2020, all hell broke loose with re-Imogen, where the judge reversed the ruling of Reed Kelvin and required, to the astonishment of many, many people across this country, both parents, clinicians, and lawyers, whereby the young person could not consent, subject to an assessment for Gillick competence. The judge decreed that for treatment to proceed, there had to be a signed consent form with the signatures of both parents. And it doesn't take much imagination to work out that this, in many, many situations, is just an impossibility. Parents may be divorced, separated, uncontactable, be in prison, hostile to the proceedings, and refuse to sign a form. And so for many different reasons, the requirement to get both parents to sign a consent form caused phenomenal trauma, both for the young people themselves, their parents, and also for people like me, looking after young people, where our options suddenly were vastly reduced. A hugely problematic situation legally and clinically. Finally, in 2022, a fascinating bit of law. What's happening here? The Supreme Court of Queensland overrode the Family Court decision on re-Imogen from 2020, and decided that pursuant to parens patriae jurisdiction, which means the state stepping in for the interests of the child, whether the application should be heard in the Federal Circuit and the Family Court in Queensland, where it was not in the interest of the child for the application for treatment to be delayed. The court declared that A was the pseudonym given to the child in question. The court declared that A could give valid and lawful consent to the administration of their own treatment, and of course that was based on Gillick competence. And so Queensland is an exception to this context, whereas in other states, sadly, the ruling of re-Imogen still applies, and a source of great trauma, as I said. Finally, how are we doing for time? So, okay, so this is really my last slide of content. So I thought I'd just look at the implications related to autism spectrum disorder, the overlap between autism, sexual health, and the law. And autism, the references you can see there at the bottom of the slide relate to Asperger's syndrome, which is now somewhat of a controversial name because of Asperger's own associations with the Nazis in Germany, but it refers to people with autism spectrum disorder who are essentially very highly functioning, so often able to perform very, very well if they're well supported and able to overcome a lot of their emotional and social issues in terms of emotional understanding and maturity. So young people with autism often engage in inappropriate behaviours in general terms, and also inappropriate sexual behaviours, which are often illegal. It's common in the area of autism for the young person to develop obsessions or very specific interests about things which may have nothing to do with sex. So the collection of various esoteric objects, for example, collections of yellow pencils and so on. But sometimes these obsessions can have a sexual dimension. And if they are consistent with an obsessive relationship with various objects or pornography, including child pornography, or with animals, so bestiality, zoophilia, and so on, of course, they rapidly enter the realm of illegal behaviour thereby. Similarly, a lot of young autistic people will not understand what's socially acceptable and unacceptable in terms of masturbating in public, for example, masturbating at school, exposing themselves, not understanding that they can't touch another person in a sexual manner without consent. And this also has a reciprocal meaning in terms of their ability to give consent. Autistic people, young people, often have major challenges in terms of understanding and understanding their own emotional responses to the way in which other people deal with them, and may misinterpret their feelings and emotions, and also their attraction to other people, and come into legal trouble in that way. And then finally, transactional sex, so selling sex for favours, including accommodation, drugs, and so on, or money. That obviously is still potentially illegal in Queensland. And certainly if they're underage, they may well find themselves exploited in a sexual manner, and that may well also carry medico-legal consequences. So as I said, a number of the things at the top of the slide are illegal. They constitute sexual offences. They may well lead the autistic person to end up in prison. In courts, on a good day, a defence for the autistic person would go into great detail about autism being essentially a mental health condition and be most of the time an appropriate defence that might protect the person from going into prison. But certainly if they were sentenced to a prison term, an autistic person may face extreme sexual abuse and exploitation within the prison. And then separately, even in the general community, they're highly vulnerable to sexual abuse and exploitation. I clinically don't see too many young people, and not the least reason historically over the last several years has been to do with the flip-flopping, as I called it, on the ability to legally provide gender-affirming treatment. Currently, we are able, as I said, to provide gender-affirming hormone treatment on the basis of legal competence. And naturally, I'm always keen to involve parents in the decision-making, but it is no longer a legal requirement in Queensland. And finally, on just also on the topic or the implications of emotional immaturity and misreading of social cues, being able to read someone's face, that becomes a particular problem if the young person is in a police interview and they may not understand that they need to be giving truthful answers, and the police may manipulate the vulnerability of the young person in interview and suggest to them that they did such and such a thing, which they did not actually do. But their autism may lead them to agree to things or saying the things they did, which they did not actually do. So with that, I am happy to take questions, and I'm very grateful for anyone who's chimed in today live, but also for people viewing this online. And so I'd be happy to take any questions. I understand there may be some questions that were provided prior to this session. So thank you very much.
Thank you, Dr. Neilsen. As Dr. Neilsen mentioned before, if anyone has any questions, please unmute yourself and you can ask away, or you can just write it in the chat. Nothing so far. Okay, all good. That was really interesting. Thank you, Dr. Neilsen. I do have a question from someone who couldn't log on today. Let me just read that out. So we're seeing an increase in syphilis, including in young children. Is this being inherited through birth, or is this from childhood abuse?
That's an excellent question. And the short answer is yes, both are possible. We are seeing a very disheartening increase in syphilis acquired during pregnancy. So young people or babies being born with syphilis, with a significant number of those experiencing pretty major damage as a result of congenital syphilis, and by damage that includes death. So neonatal death due to congenital syphilis is well and truly on the increase. And I was trained at medical school that congenital syphilis was a condition that should never be seen in a wealthy country such as Australia. But it's really becoming an increasingly serious problem. It may be missed when the baby is born, and so the baby may well go on to become an infant and become older and display symptoms that are related to syphilis at even years later. So so the possibility of acquiring the infection from their mother is very much a problem, and an increasing problem at that. And then, of course, sexual abuse, transmission from another person. Syphilis is a highly infectious condition and easy for a young person to acquire during all sorts of sexual activity. not necessarily penetrative sex. So secretions from a lesion can be transferred to a young person through fingers, through kissing, in unusual circumstances, I must say, but generally speaking, it would be through penetrative sexual intercourse, be it oral, vaginal, or anal. So yeah, and medical legally, very, very important, and raising the spectre of the forensic issues, as I described earlier. So blood testing for syphilis is in a different kettle of fish from the blood testing for herpes and chlamydia trachomatis that I mentioned earlier. So blood testing is a very important aspect of the diagnosis and management of syphilis, and changes in syphilis serology would be of evidentiary importance in the courts as well.
Awesome. Thank you for that, Dr. Neilsen. If nobody else has any questions, we will end the session.
All right. Well, thank you, everybody, and thank you, Gina. Great to meet you today.
Yes, likewise, Doctor.
Interesting to see what comes of it.
Yes, thank you so much for your time and making the time to come on and share your knowledge in your expertise. So that was really informative.
Right.
I quite enjoyed it. Thank you, Dr.
Thanks very much. And yes, I did too, because as you can tell, I hope this is an area of passionate interest for me as well.
Yeah, awesome. Oh, you have a great day. Thank you, Dr. Neilsen.
Thank you.
Bye.
Bye.